Hello and welcome to YHTV's Magical Medical Tour. Thank you for joining us today. I'm Christina Suzama, and with me is our wonderful medical guide, Dr. Glenn Wolman. Hello, Doc.
Hello, Christina. How are you?
Wonderful.
Good.
It's another exciting day.
Yeah, we're going into a real serious realm here today. Greetings, everybody. Welcome to Magical Medical Tour. I'm Dr. Glenn Wolman, and I will be your medical guide along with Christina as we travel through another quadrant of the healthcare galaxy looking for optimal health. And today we're going into the area of mental health with Dr. James Lake. He's an integrative holistic psychiatrist. We're continuing our program. Last week we were with Jeffrey Swartz, who still is actually, PA, and he works in psychiatry and mental health in New York. We had a very nice discussion with him. Today we're going to continue our mental health exploration. Christina, tell us how to get in touch.
Yes. Now, at any time during this show, you can feel free to ask a question or make a comment simply by scrolling down on your screen and typing it into the comment box. Now, you may be watching this show a year later, any time. It does not matter. We will make sure that your comment or question gets to our guest or Dr. Wolman, and we will definitely send you a reply. Or if you are listening to this on a device like through iTunes, simply give us a call at 818-LETS-TALK, 818-LETS-TALK. Thank you, Glenn.
You're welcome, Christina. Thank you. So today we're going to be speaking with Dr. Lake, a psychiatrist, and this is very exciting for me. We haven't had a psychiatrist on yet. He was a clinical assistant professor in the Department of Psychiatry and Behavioral Medicine at Stanford. He's currently in private practice in Monterey, California, and he's also a visiting assistant professor of medicine at the University of Arizona's School of Medicine and their Center for Integrative Medicine. And this is very important because it seems like a lot of the things that Dr. Lake does has to do with bringing on the complementary and alternative medicine aspect to mental health. He's an author of many books, and he has just written a number of ebooks. He also writes a number of articles for various magazines. He's published. He also has chaired caucuses nationally and internationally and at the American Psychiatric Association, always looking for ways to improve mental health care and bringing on an alternative and complementary medicine aspect to mental health. So without further ado, I would like to introduce Dr. James Lake. Welcome, James.
Thank you for the gracious introduction.
Hello, Dr. James Lake. Thank you so much for honoring our community.
It's my pleasure. Thank you for the opportunity.
James, we're going to take a little tour here, and as the medical guide, I like to tell our audience where we're hopefully going. First, we're going to learn a little bit about you, why you became a healer, and why psychiatry and integrative psychiatry. Then we're going to get into some aspects of consciousness and mind and mental health and many of the things that you're doing to help people figure out what's going on in their mental order and disorder. How's that sound to you?
Sounds great. Let's go.
Good. Excellent. So first, we want to know what got you interested in becoming a healer, and then why psychiatry, and then how integrative psychiatry. And I'd like you to include in that the question that everybody always asks is, do all psychiatrists go into psychiatry to figure themselves out?
I'll keep that in mind as a subtext of your major question.
Thank you.
I've always been interested in consciousness. I've always been interested in the general problem of consciousness, and in humans and in animals. In undergraduate days, I studied primate behavior, and I had the opportunity to work with Jane Goodall at Stanford at that time.
Nice.
And became fascinated with how primates behaved. I tried to imagine, stepping in their shoes, if you will, in the jungles of Africa. And from that, it was a natural choice when going to medical school some years afterward to continue on in the trajectory toward psychiatry as a medical subspecialty. Because in psychiatry, although the emphasis in contemporary psychiatry is on medications and psychotherapy, the underlying issues have to do with the nature of human consciousness, both in its normal sense when people are healthy and functioning, as well as, of course, what we call pathologies or disorders of consciousness. During medical school, it became very clear already in clinical rotations in psychiatry that the available therapies and theories that guide clinicians in understanding and treating mental illnesses were not adequate. They could not adequately explain both the nature of consciousness and, by extension, pathologies of consciousness, nor were the available therapeutics adequate to the task of treating mental illnesses or providing adequate approaches for maintaining optimal mental health, optimal wellness. So very early on in my career studying medicine as a medical student, it became clear that the available so-called traditional biomedical model of psychiatry was not adequate to meet the task of both understanding the nature of consciousness and pathology related to consciousness, as well as treating these disorders. That led me to begin to explore at a very early stage the whole range of what we call in Western culture alternative and complementary therapies, which are, as you well know, Dr. Wolman, accepted as mainstream approaches in other world cultures, such as China, for example, where acupuncture and herbal medicine are accepted as mainstream, and biomedical approaches used in Western cultures are viewed as alternative. So in a nutshell, this is where my perspective was informed. This is the trajectory that led to where I am at this point in time as a clinician, as a writer and teacher.
Were you trying to find yourself?
I managed to avoid the subtext question.
Yes, you did.
Thank you for reminding me. There's always some of that. I think many people, though perhaps not all, who go into psychiatry have some personal issues that they're working out during that time. During the residency training, it's strongly recommended, though not required, that you undertake long-term psychotherapy, just so that you'll be a more competent therapist, to be able to step in the shoes, if you will, of your patients, understand them from their point of view. So I did it for those reasons, and along the way I was able to do some important work on my own dynamic issues, family and interpersonal dynamic issues and so forth. It was very valuable.
Beautiful. Before we actually get into all of the meat of the program today, for those that are thinking about a career in medicine and possibly psychiatry, what is the training involved in a psychiatric practice?
So as for any medical subspecialty, pediatrics, gynecology, surgery, so forth, family medicine, you first need to go through a 4-year medical school curriculum. You learn the basic sciences. You go through 2 years of what are called clinical rotations that involve introduction to all of the major clinical areas of medicine that I've mentioned. And then you do an internship. In the case of psychiatry, the internship is typically divided between neurology and psychiatry. That's 1 year. Afterwards, you do a 3-year residency specializing in psychiatry only. About half of that is inpatient, half of that is a variety of outpatient clinical experiences. During that time, typically you have supervision from people with specialization in a variety of areas of psychiatry, what we used to call organic psychiatry, the interface between medical illness and psychiatric disorders. You learn a great deal about different kinds of psychotherapy from mentors who work with you on an individual basis, on a week-to-week basis and so forth. You take a lot of call in emergency rooms so that you have some experience, as you're very familiar with Dr. Wolman as an emergency physician. And so that you have a lot of experience managing people in crises, coming into emergency situations, which is really an important opportunity for getting them back on a stable track. So you have the whole variety of experiences, inpatient, outpatient. There's a lot of overlap between neurology and psychiatry. So psychiatrists study a great deal of neurology. Neurologists study a great deal of psychiatry in their training as well.
What about integrative psychiatry? Is there a training in that?
There are a few programs that are currently bringing that paradigm into the mainstream. The University of Arizona Center for Integrative Medicine has a module on integrative mental health care that I helped to co-author many years ago. This is now a distance learning program, but they are committed to bringing that information to their fellows. The majority of their fellows in Dr. Weil's program in Tucson are family physicians. I believe over 90% are. And in fact, that's not a bad thing, because the majority of day-to-day mental health care is provided by family physicians. They have good and broad training in that area. There's also a PhD program in integrated mental health care at Saybrook University, which is largely an online program, but I believe they have 2 one-week intensives during the course of the year. There are some courses in integrative psychiatry in some psychiatry residency programs in the U.S. and Canada. And I believe it's achieved a much deeper and a more formalized place in the European Union countries as well as Australia. So it depends on where you are geographically as to how difficult or easy it will be to get this kind of training. But it's emerging. It's becoming more widely available over the years.
Yeah, I'm very glad of that, and I know a lot of people are very glad of that, and I think we'll get into that in a few minutes. So at the beginning, you used the word consciousness quite a lot in your brief introduction to yourself. What is consciousness?
This is the $9 million question. I've thought about this quite a bit, written some articles about this. I've been involved in some research projects looking into particular aspects of the role of intention in healing, which is a very interesting aspect of consciousness. So my short answer to your question would be that the way one defines consciousness, or where you can get to in terms of a definition, depends on the premises you begin with that frame the question itself. If your premise is that consciousness is a kind of phenomenon or thing that has to do with living organisms, then you limit the kind of definition to a phenomena that can be associated with animals, typically higher order vertebrate animals like primates. Humans, some people believe, are at the pinnacle of that hierarchy. If you define consciousness in another way, you can get to the point of thinking about consciousness as unrelated to or indirectly related to living creatures or physical objects. This is the whole field of panpsychism. In the area of medicine, the dominant theory of consciousness is called functionalism, which states that consciousness can be defined as what the brain does. The neural circuits underpinning perception, higher abstract reasoning, and so forth constitute what consciousness is and can be. I think that's a very limited definition. I don't subscribe to that because that doesn't permit you to take into account what's been observed in many cultures over many decades, when healers direct intention toward patient and healing results by empirically measurable outcomes. So I don't think that's an adequate model, and I think that's also slowly evolving to a more comprehensive, more adequate explanatory model within medicine.
Is consciousness the same as mind?
Again, some writers and theorists would claim that consciousness and mind are synonyms. They might claim that the functions of consciousness are another way of describing or explaining what mind does, or the phenomena that collectively are interpreted as mind. This has to do with linguistics and the philosophical argument that you begin from, how you argue toward that. I think these are different kinds of things, different kinds of definitions, and some people would equate them as identical kinds of things.
It seems to me that in talking about autism, for example, where it's now become a spectrum disorder, so we now look at it as a spectrum, it seems to me that health, mental health in particular, is also a spectrum, where we're either on the disorder portion or the order portion. Do you have any thoughts on that?
I'd like to add a footnote to my answer to your previous question, because it dovetails beautifully into this question. The current understanding of autism is that autism has to do with an inability to have a theory or understanding of mind of another being. People who have severe autism lack the capacity to project, if you will, a sense of mind or consciousness into another person, another creature. So it's a good segue into your question about autism. I think that there's a lot of controversy still over the concept of spectrum disorders in general. I think that with the DSM-5 in particular, there was an effort to promulgate even more divisions between the previous hierarchy of disorders in the DSM-4 TR version. I'm not an autism expert. I can't comment specifically on the advantages and limitations of the new revisions to diagnoses of autism. But I know that there is a concept that has come out both with respect to categories for diagnosis of autism and ADHD that talk about subthreshold symptomatology, in which case some individuals may experience some very clinically minor symptoms that may interfere with their capacity to function in very minor ways, but they might be viewed as on a kind of a continuum that would include more severe forms of this disorder, such as Asperger's and autism and so forth, but be viewed as having subclinical symptomatology. And I think there's ongoing debate in the academies that focus on this subject at this time.
You know, you brought up the DSM, the Diagnostic Statistical Manual, right? And that's what basically is all of the mental disorders. And as we've looked at that through the years, how does culture play a role in that? For example, when we were talking, I believe, with Jeffrey Schwartz in our last talk, we brought up the concept of homosexuality at one point being a mental disorder. And now that our culture has looked at it differently, it's no longer that. So I wonder, when we come up with these ideas and we suddenly put a label on someone, that stays with them. What's the process of deciding what is a mental disorder, and how does that happen?
These are very good questions. In general, the process within the American Psychiatric Association of determining what comprises a mental disorder takes place at the level of committees, which are typically staffed by academics who have expertise in the various so-called psychiatric disorders. These committees typically meet for over a period of several years. They go through the literature. The work typically begins with an extensive review of the peer-reviewed literature, which by definition, from my point of view as an integrative psychiatrist, is limited to only those kinds of studies that would be published in the first place in the peer-reviewed medical literature in Western medical journals.
Good point.
Yeah, there's a lot of bias there. That's not so obvious unless you begin to look for it. But clearly there's bias, self-serving bias in my view. So at the end of a period of time defined by the American Psychiatric Association process for reviewing and revising the DSM criteria, the committees will typically reach consensus, which will lead to revisions, if indicated, of diagnostic criteria. Some of those revisions might result in adding new categories, new subcategories to a particular disorder, or they might stay the same. So that is the process. Some people would argue that there is a lot of politics and influence that enters into that process that is other than the kinds of academic research considerations that should enter into that process. For example, it's been argued that some people who have been on committees with respect to the bipolar diagnostic categories may have had self-serving interests that may have led to extending diagnostic criteria in ways that would justify prescribing medications to people who before this period of time were not appropriate candidates for medication. This goes back to the sub-threshold idea that I mentioned earlier. There's some debate in academic circles and in general about that. Alan Francis, former chair of the American Psychiatric Association, has written a book which is a scathing critique of not only the DSM-5, but the process that led to the revisions that are now embodied in the DSM-5. I would refer your listeners to that if they want to go into this in more depth.
So psychiatry sounds like needs a psychiatrist.
Yeah, some would argue that there are some, as is true with any large organization that represents enormously diverse issues, within a professional population, there could be some opportunity for reworking how things are done at an institutional level. I'm going back, Glenn, to your earlier question about culture and the role of culture and how considerations of culture come into the DSM process. It's a very important one. Dr. Francis Lee, who was a chair of the first endowed program in cultural psychiatry at UC Davis until his retirement a few years ago, was at the head of the American Psychiatric Association committee effort to bring considerations of culture into the mainstream within the APA process and Western culture in general. He and his committee set this up and made this happen. They created an appendix on issues related to culture for the DSM, which has been part of the DSM for several iterations at this point in time. And from the Western biomedical perspective, which is what the DSM-5 is about, there are so-called culture-bound syndromes, which from this Western biomedical perspective represent particular kinds of behavior or somatic manifestations that take place in the context of particular cultures. We view as representing psychological distress, which individuals who experience them in the host culture may view as spiritual imbalance, energetic imbalances. So it's an effort to map on Western biomedical criteria, reductionistic criteria, to kinds of experiences that may not be fully explainable in terms of our Western kinds of biomedical reductionistic criteria. In other words, someone in Southeast Asia might experience a spiritual crisis. We would interpret that within the DSM process as a culture-bound syndrome. And they would view that as a kind of a very disturbing spiritual imbalance, perhaps possession or other. So depending on where you begin, you start with different philosophical premises about what is real, how phenomena are manifest, and you get to different assumptions about the causes of disorders, the nature of disorders, and by extension, how you can treat them and make them better. Very different sets of premises, starting at a basic philosophical level in Western biomedicine and in other major world systems of medicine, such as Ayurveda, Chinese medicine, and others.
We spoke with Dr. David Tresimer, also a psychologist, who spoke of anthroposophic psychology using the spiritual. So I think that that's what you're alluding to in part of this cultural aspect of mental illness. Approximately how many mental disorders are there?
You know, I would be guessing.
That's all right.
I did a very interesting exercise with a former teacher of mine at Stanford during my residency days, who had actually retained copies of the original editions of all the DSM books, starting back, I think, in the late 60s, early 70s. And it was quite an interesting exercise to do. There were several residents who met with him and took a look at this. The first one, I believe, had fewer than 100 disorders, with very few subcategories, subtypes of disorders, if you will. And the second one may have had, significantly more disorders. I believe that the number of disorders really multiplied quite rapidly between the DSM-2 and DSM-3. And that has continued, perhaps almost doubling the number of so-called disorders from that time to the DSM-4, the DSM-4 text revision or TR, and then again the DSM-5. I think that there was a debate among committees and among people who watched the DSM process unfold over these various versions of the DSM over the decades about whether disorders should be split into further subcategories or lumped into other major categories. The DSM-5, although there is much room for criticism, I think it's made some progress in that they have embraced a concept that hasn't been part of the discussion, the thought world, if you will, within DSM until this point in time, which is continuum or spectrum disorders instead of discrete categories. The idea being that there probably aren't very many discrete kinds of pathology, but things vary in subtle ways along a graded continuum spectrum. That works, I think, quite well for certain kinds of mental health problems, but it may not be appropriate or valid for other kinds. And that discussion is taking place. So there are problems with the DSM process, but I think also there has been progress compared to where we were before.
So let's talk about psychiatry in terms of treatments. We know about talk therapy, we know about drug therapy, we talk about electroconvulsive therapy. And now that we have neuroimaging and the genome, we're starting to learn a lot more about causes of mental illness and possibilities for treatments and solutions. So I'd like you to address some of the treatments and solutions, and I would also like you to add into that how intention plays a role in mental health and healing. You brought that up a little earlier.
Mm-hmm. There are many ways of categorizing treatments in medicine generally, and certainly in psychiatry. One way of doing that is to think of certain treatments as biological treatments. That would include, of course, medications. Mm-hmm. And then non-biological treatments, for example, psychotherapy. Biological treatments would also include electroconvulsive therapy, transcranial magnetic stimulation, bright light exposure therapy, what has been called high-density negative ion exposure therapy, which is a very interesting emerging treatment that might be beneficial for severe depression. So the idea is that there are many kinds of treatments that address the causes of mental health problems at different levels, and the very complex system that makes up the human body, brain, mind, soul, if you will. Depending on what you're looking at and what you consider to be the cause of the disorder, and usually there is more than one cause, you might more likely target a biological cause using a medication, for example, or you might more likely use psychotherapy as the mainstay of your treatment plan. In my experience doing this work for over 20 years, it's very rare that you find an individual who has only one kind of cause for their particular mental health problem. This is an invitation for integrative approaches, because by definition you're putting together an individualized plan that addresses numerous layers or kinds of causes of depression, anxiety, whatever the major issue is. And also typically you won't just have one particular problem. You might have anxiety and depression. In fact, the majority of people who have a difficulty with depressed mood also have anxiety. Many of them have a substance abuse problem as well. So you're approaching complex problems, usually multiple problems, using a formula of different kinds of treatments that address different kinds of causes, and a constellation of multiple mental health problems that often go together. Symptoms are waxing and waning over time. I think that none of these contemporary approaches in the biological sphere replace or can displace psychotherapy. I think psychotherapy is essential and extremely valuable for anyone who is working on a mental health problem of any kind, even people with severe disorders such as schizophrenia and bipolar disorder, for giving them more grounding capacity for stabilization, for reflection. This indirectly goes to the second part of your question, which is about intention. If an individual practices mindfulness using a structured method or a very simple practice of counting breaths to achieve relaxation, a sense of inner calmness, there are many studies that have shown that they can attain more equilibrium, if you will. They can achieve some significant reduction of the severity of their symptoms, whether it's anxiety, depressed mood, psychosis, post-traumatic stress disorder, and others. The other layer at which intention probably plays a role, and we're just beginning to learn about that using functional brain imaging research approaches, has to do with directed intention from a healer to an individual, or from the individual to him or herself, through prayer, through meditation, through guided imagery. There are many studies that have been done using advanced functional brain imaging technologies such as functional magnetic resonance imaging and so forth that show that there is a consistent relationship between intention directed by the individual inward to serve healing, or intention directed by a healer, such as a Reiki master, a Qigong master, a Kahuna, traditional Hawaiian healer in Hawaii and so forth, and changes in immunology, and immune function, and brain function, and in clinical symptomatology for many disorders, including many so-called mental health disorders. So there's an emerging story there that's quite interesting.
Yeah,
and I think
definitely.
The go-to person, the expert in this area is Dr. Larry Dossey, who has written many important works. The one on this particular subject would be Healing Words, but many important works on this area of the relationship between mind and healing and intention.
Larry Dossey also talks about non-local healing.
Exactly. When you talk about healing, by definition, you need to bring in the considerations of non-local healing. When people gather by hundreds in Washington, D.C., and they engage in transcendental meditation for a week, and you observe statistically that there are significant reductions in the rates of crime and of all sorts. And that study has been repeated many times recently, I believe, in other cities. There, you cannot but conclude that there is a relationship between non-local intention and change in human behavior. And one particular type of human behavior would be what we call symptoms of mental health problems, mental illness. There's a general kind of phenomena going on, and I think between intention and human behavior and how mind functions. And I view the relationship between intention and illness or mental health problems as one particular dimension of that more general kind of relationship.
Do you think if we were able to get the entire world, everyone in the planet, to spend 1 hour in compassion all at the same time, we would be able to change the world?
I think that if we were able to somehow align conscious intention among people from all cultures and all spiritual traditions for any amount of time, there will be a significant and noticeable change in how people behave and how they regard other people. And I don't know how long that would last. My guess is that there is so much on the negative side at this time that it may not be a complete or enduring fix. But an hour a week, perhaps, maybe an hour a day. There's so much darkness there.
I can start with 5 minutes. If everyone would do that 5 minutes, that's something already.
5 minutes is realistic. Yeah,
yes.
yeah.
A little bit. Dr. Lake, a question has come up. You had mentioned non-local healing. Can you give me a definition of that?
So the general concept of non-local healing is that intention is directed either by an individual to another person or animal or plant, or by a healer to another person or animal or plant. And that by virtue of something that may happen in space-time between the person sending intention, directing intention, if you will, and some mechanism at the level of mind-brain or energetics that haven't been clearly defined by Western science, there is a change in the animal, the person, the plant that improves functioning, that results in increased capacity to function. At the level of human illness, that might manifest, for example, as improved immunologic function, fighting cancer, fighting HIV/AIDS. In terms of mental health care, that might manifest as someone who reports fewer or less severe symptoms of depression or anxiety following non-contact or non-local healing. There have been studies that bear this out in several areas of so-called energy healing, which might more aptly and correctly be called information healing, in my view. It's more like a coextensive information wave that encompasses two separate systems in space-time. But the word used today for this kind of phenomenon is energy healing. So it's more than placebo. Placebo has been ruled out in many, many cases. Many studies have been done. It's still beyond the means of most people who've studied Western medicine and practiced medicine in this tradition to understand and to work with in their day-to-day clinical work, because it's outside of the theory and the clinical therapeutics that are accepted as part of what Western medicine does, how Western medicine conceptualizes the world and what's possible. And again, I would refer you to Dr. Larry Dossi as the dean of this area. Yeah, he's the preeminent expert.
Yeah, and Christina, part of it, just an easy example is normally you would picture a psychiatrist in a room with a person and talking to them, right?
Yes.
Whereas the non-local means that psychiatrist or that group of people could be in another country,
yes,
and they're sending an intention. So that's my understanding of what Larry Dossi speaks about.
The interesting part of that, go ahead.
No, continue.
Yeah, the interesting part of that, Glenn, you made a very good point here, is that the idea that's emerged from many studies, good studies, well-designed studies, well-controlled studies over many years now, is that distance may not play a role in healing when intention is involved. In other words, you get the same kind of effect whether a person is 10 feet away, 10 miles away, or on the other side of the planet.
Let's talk a little bit about traditional psychiatry and integrative psychiatry. Give us a little bit of the difference of the two of them, and also tell us, because you've been at the forefront of this, tell us some of the initiatives you brought forth, the caucuses, the ideas that you brought forth, paving the way for integrative, complementary, and alternative modalities in mental disorders.
In very broad terms, the model that's used in the West and broadly in many other world regions is called the biopsychosocial spiritual model. And according to the textbooks, according to what our teachers teach us in residency programs in psychiatry, the concept is to approach each patient from the perspective of biological underpinnings of illness, psychological underpinnings, social, cultural underpinnings of illness, and also spiritual. So in recent decades, the paradigm was extended from biopsychosocial model to biopsychosocial spiritual. So that's part of our formal training. It's endorsed by contemporary mainstream psychiatry in Western countries. However, when you look at how psychiatry is practiced clinically, you often find situations that depart from the orthodoxy that we're given during our training. For example, the majority of clinical psychiatrists exclusively practice psychopharmacology. We prescribe meds, we refill meds, we comment on meds. There's a lot of knowledge and expertise required to do that well. And there's a reason that psychiatrists do that. This very complex part requires a lot of sophistication, a lot of effort to do that well. The people who practice psychotherapy and do other kinds of work at the level of social interventions, psychological interventions, and so forth are typically trained in other domains. They're psychologists, social workers, and so forth. The spiritual part tends to be lacking, tends to be outside of the contemporary paradigm that's embraced by Western biomedical psychiatry. So this is the contemporary model. You might consider it integrative. Some people who write about this call it integrated, and that psychiatry, when done well, really needs to work closely together with the medical subspecialties, because many people who have significant medical disorders often have psychiatric issues and vice versa. So integrated from the perspective of biomedical psychiatry often means that you're working hand in hand with a family doctor or a neurologist, a cardiologist, to kind of tease out interconnections between their medical problems and their psychological or psychiatric issues. That's not what we mean by integrated mental health or integrative psychiatry in this new sense of the word that we've been talking about today, which includes not only the conventional biomedical approaches that are valid and have been substantiated by decades of research studies, but includes also evidence-based complementary and alternative approaches such as herbal medicines, vitamins, omega-3 fatty acids, amino acids, other kinds of natural supplements that have been found to be quite effective for both treating or preventing particular mental health problems. Integrative psychiatry or integrated mental health care, which is a broader way of phrasing it, also encompasses the whole range of mind-body practices, what I call somatic approaches, such as massage. Physical exercise is fundamentally important for most people, particularly people working with depression. Then there are the energy and information approaches. This is a paradigm that I developed in my previous writing and teaching. Some energy approaches are validated by current science, such as bright light therapy for depression, for seasonal affective disorder, such as EEG biofeedback, electroencephalographic biofeedback, other kinds of biofeedback. Then there are these so-called subtle energy therapies that have not yet been validated by Western science, but may in the future, such as Reiki, healing touch, Qigong, therapeutic touch, thought field therapy. Some of these may eventually be validated by Western science. Some may be rejected. The interesting point, Glenn, is that if you expand the paradigm of Western science in general and look at these kinds of phenomena from the point of view of quantum mechanics, a broader paradigm, not just 19th century Newtonian mechanics, but quantum mechanics, you soon get to a point where these kinds of phenomena you see in the name of energetic healing or subtle energy healing are not only possible, but expected. And I think that's where medicine is heading. We're at a very interesting place now.
Yeah, that's very exciting, especially to be thinking of all of the healers. We've interviewed a number of them on Magical Medical Tour that work with energy, and it's good to see that that's being incorporated, especially into something so important as mental health. Continue.
So thank you for asking me to comment on organizations that are trying to bring this new way of thinking about mental health care to the forefront and to bring it into mainstream practices of mental health care in this culture and globally. In fact, there are two initiatives that I've been involved with. In fact, I helped to found them and I've chaired them in the past. One is the American Psychiatric Association Caucus on Complementary and Alternative Medicine, which has been ongoing since 2004. This is a group of psychiatrists who are members of the APA, who have established an expert-level website, who put together symposia within the APA annual meetings, and are committed to teaching psychiatrists about the evidence-based, responsible, legally safe approaches of complementary alternative care, addressing the range of mental health problems. The other one is called the International Network of Integrative Mental Health. And this is a global nonprofit organization that was established in 2010 that I helped to found and that I chaired initially. This is dedicated to promoting an agenda of advocacy, teaching, research, and collaboration across specialty lines, across cultures and national boundaries, with the goal of improving the quality of mental health care in general, making all of these treatment approaches more accessible to people, regardless of where they may be located. So these are two organizations that are really the vanguard of this movement, that are working to promote an agenda for transforming mental health care into an approach that's more person-centered and more complete, hopefully more effective and humane as well.
I have to say congratulations on doing that. You know, in medicine, we're mainly about tradition, and to take on new aspects and move into the future for the sake of helping people. This is great work on your part.
Thank you. It's slow going, but we're making progress year by year.
Of course. It's been slow going in all of complementary and alternative medicine and all aspects of medicine. You know, James, we always talk on this show about prevention of different injuries and illnesses. And you've alluded to a number of things, breathing practices and exercise and other therapies. Do you have any thoughts on preventing mental illness? And the other aspect would be, is there a way to maintain any exercises that we could do to maintain a healthy mind?
Very good questions. I think that the emphasis in clinical mental health care for any mental health professional, psychiatrist, psychologist, social worker, family therapist, should be equally divided between treating and prevention. Prevention typically comes in the form of advice on maintaining optimal wellness during therapy sessions. Very simple lifestyle changes adhered to consistently day to day go a very long way toward preventing mental illness, or if you have a history of mental illness, toward reducing the chance of relapse, toward recurrence of severe mental health problems, whatever that may be, particularly in the case of depression, anxiety, but also other mental health problems. I think that exercise is fundamentally important for prevention and for reducing the chances of relapse. There's good evidence for this in the case of depression and anxiety. There's less evidence, but still some evidence for bipolar disorder, psychosis, and other kinds of disorders. Good diet is another important, I call it, pillar of preventive medicine, both with respect to many medical conditions as well as mental health problems. I always advise my patients to carefully review their diet. If they have any kind of mental health problem, I review this with them during the session. And if there are apparent gaps in their diet, if they're eating junk food, for example, or skipping breakfast, which many people do in this frenetically paced world, I will try to encourage them to change their diet, to look at that as an important part of prevention, maintaining wellness. Another pillar of prevention or wellness, if you will, is a simple relaxation or mind-body practice. You don't need to go to a retreat. You can engage in a very simple breathing practice or guided imagery practice, 10 minutes in the morning on the way to work, using a guided imagery CD or something you download on your iPhone, and again in the evening. So exercise, a good diet or dietary change, if that's indicated, a mind-body practice or relaxation. These are pillars of what we would call prevention or wellness in both medicine and mental health care in general.
Very nice. Do you think that our society is on too many medications?
Absolutely.
And all right,
that's an easy one.
We do love to hear that one, don't we?
I think this is a widely shared concern among psychiatrists as well. I think there's agreement among psychiatrists that people are over-medicated for many reasons. Psychiatrists and other clinicians who prescribe psychotropic medications are very busy. Certain kinds of medications are inappropriately prescribed or overprescribed for the wrong reasons, such as stimulants to children whose parents want them to focus better, to do well on their SATs, such as to elderly persons in nursing care homes who are demented and agitated, who have too high or too frequent a dosing of potent sedative hypnotics. They become addicted to them. They have fall risks. They have enormous medical complications that may mask the progression of their neurologic disorder, dementia, whatever it may be. Antidepressants are enormously overprescribed, often not reviewed and not changed for a long time after they're prescribed. There are many examples of this. It's a serious issue, and I believe that most psychiatrists would agree with this. There's a collusion between big pharma and institutions that promote this kind of thing, and there's a lot of money going into advertising all the time, though I believe there's been some pushback on this particular theme within the APA committees. People are trying to recorrect that course. I don't want to paint myself as an anti-psychiatry person, because I'm not. There's a lot of good work. There's a lot of good work going on within the kind of conservative circles in the APA and academic psychiatry. And there's also the shadow side of this, where the long reach of the big pharma is attempting to influence policies within the FDA, APA, and academic circles and so forth. So it's a mixed bag. There's not a simple picture. But in general, medications for treating mental illness are enormously overprescribed, inappropriately prescribed, not monitored adequately, resulting in enormous safety issues for, I think, millions of people. I mean, you could examine the water, I think, in New York City 20 years ago and find Prozac, right?
Right. So now when we talk about that and we talk about integrative psychiatry, there might be some psychiatrist that's saying, for your depression, let's take valerian root, for example. Should we be looking at that the same way that we're looking at Prozac?
Very good question. And the simple answer is yes. They should comply with the same criteria for safety and efficacy. There should be no difference, ideally. In other words, if you are approaching someone as an integrative clinician, you should approach them with equal footing both with respect to offering them choices on the conventional side, as well as to offering them evidence-based choices on the alternative and complementary side. The idea is not to find an herb or mindfulness practice to replace the need for a psychotropic prescription drug. The idea is to find the best fit, individualized treatment plan that addresses them with respect to their particular symptoms, what the evidence suggests, and in addition to that, what they prefer, what they can afford, what's available to them, where they live, where they reside. This is about person-centered medicine, or integrated medicine as we call it. These are the principles of integrated medicine. In some cases, for example, a patient might walk in to see me, and they may have failed trials on 3 antidepressants because they didn't work or they caused side effects that they could not tolerate. In that case, I would probably begin talking with them about some of the more validated natural supplements, such as SAMe, S-adenosylmethionine, or supplementing an antidepressant with a particular kind of folic acid that works very well in the brain, and some people gives them that added push that can help them with depression. On the other hand, a patient might walk in later that day who has tried St. John's wort, SAMe, 5 other natural supplements without effect, or complaining of side effects, had to quit, had to stop taking them. Herbs can also cause side effects. They can also be dangerous. In that case, I might logically, if I'm being ideologically neutral, as I should be, I might talk to them about several prescription antidepressants and begin them on one that might be appropriate for them given the severity of their symptoms and what I know about what has worked and what hasn't worked for them in the past. So the idea is that you start from an ideological neutral place and you consider the range of treatment approaches on both sides of the fence and not being committed to one particular type with respect to the patient's needs, with respect to their interest, what they can afford, what's available to them through insurance or where they reside. This is the concept of integrated mental health care in a nutshell.
Yeah, that's very good. Very good summary there. Now, you've written a number of books, clinical books for psychiatrists and health practitioners, but you've also recently written a number of ebooks for the general public on mental health. Is that true?
That's correct. In the past few weeks, I published a series of 10 short ebooks on integrated mental health care. The series is titled the Integrated Mental Health Solution. They're available on Amazon. They're available on Smashwords. The idea behind this project was to create a practical resource that was affordable and accessible to anyone, anywhere, that would permit people who have several common mental health problems, there are 9 I cover, to get a very clear introduction to both the concepts of integrated mental health care as well as the best evidence for non-medication treatments that they may use for treating particular symptoms or maintaining wellness if they're feeling stable at this time. There are also sections in these ebooks that talk about appropriate indications for combining them with medications, when not to combine them, when it may be appropriate to, in a safe way, when it may be dangerous or contraindicated to combine them with medications. That's the integrated part. So these are now available. I think they cost $4, to download.
Seems reasonable for mental health.
Yeah, my intention is to translate this into several languages and try to get the word out to different world regions in an effort to educate people about what's available outside of medications, but also to point back to the fact, to point back to organizations like the International Network for Integrated Mental Health and the APA work that are ongoing, so people will have some hope that there is more out there than what may be available to them and limited where they live. But this is the goal behind the ebook series.
Very good. You're about to travel to Tibet, and you're going to be working with healers and psychiatrists. What's your purpose other than just to be in Tibet?
I'm going to a region of Tibet called Amdo, to the city of Sining, where there is a major Tibetan hospital. Tibetan medicine is a tradition of healing in its own right, which overlaps somewhat with Ayurveda from India and Chinese medicine. but it has its own unique principles and therapeutics as well. I've been fascinated by this medicine for many years, been a student of it for some time. The trip will have two purposes. One will be to be a student again in an intensive course on Tibetan medicine. And then I hope to spend time meeting with leaders of Tibetan medicine, leading thinkers, leading clinicians who practice Tibetan medicine, to begin planning for an international symposium in the coming years that will involve both Western trained mental health professionals and leading Tibetan physicians, the purposes of which will be to build bridges for collaborative training, education, perhaps research in the future. Tibetan medicine, I think, has an enormous amount to offer Western medicine, particularly in terms of mental health care. There are herbal treatments, other specialized kinds of somatic treatments, as they describe them, kunye and other treatments that I think could bring an enormous amount of relief to suffering that we cannot adequately address from this perspective of biomedicine. And my understanding is that the Tibetan physicians who I am about to meet are also interested in building bridges of this sort. There is a major network of Tibetan physicians who carry on trainings and collaborative research in Western Europe. It's been there for some time now. So my hope is to bring that into the U.S. more so, and to bring a voice to collaborative work between mental health professionals, again, in this country, and Tibetan physicians who specialize in treating mental health disorders from their point of view.
It'd be great to have you come back after your trip and have another discussion with you to see how you look at things differently and what might be happening in the future for world mental health. And speaking of world mental health, if theoretically and hypothetically, if our species in general came into your office to see you, what would your diagnosis be?
Could you repeat the question?
Yeah, I'm trying to say, in terms of mental health of our species right now on the planet, how would you diagnose us?
You know, if you're in this field, and if you're pushing back at the edges and trying to bring in change at the level of systems, to do it for any amount of time, you need to be an optimist, by definition. You need to believe that what you're doing and what you're committing your time to doing will make a difference, ultimately. So I am an optimist, by definition. I have to be. And I'm an optimist with respect to the health of the species. I think that whereas we see the horrendous consequences of terrorism, of famine, of starvation, of political unrest, repression, in most countries of the world, that's the tip of the iceberg. That's the negative tip of the iceberg. That makes media. People want to look at that stuff on internet and on TV and so on. But by the same token, there are tens of billions of individuals practicing compassion, doing healing work every day, living their lives, trying to live their lives simply, to cut out a living, to make the world better. You don't see that on the national news. You don't see that on CNN. It doesn't make the press. I think there's much more of that going on than the negative. I'm sure
there's hope for us.
Oh, yes, of course.
Excellent. We're speaking with Dr. James Lake, an integrative holistic psychiatrist, and we're coming to the end of the show. James, do you have a health tip for us?
My health tip would be individualized, depending on where your viewers are in life, what would be appropriate for them to change or not in lifestyle. And I would go back to earlier comments about lifestyle, prevention or optimal wellness through changes in lifestyle. Keep it simple. Reevaluate whether you exercise enough, whether you manage stress adequately, whether your diet is healthy. I forgot to mention sleep. Sleep is fundamentally important. If on looking at your lifestyle, you find during that review that you don't exercise at all, that a simple walk for 10 minutes twice a day would help you feel better, physically and mentally. Think about doing that. If on review you notice that you're not eating well, you're eating junk or not eating adequately, think about that. Think about how to shore that part of life up. Shore up that part of life so that you're eating better day to day. If you're not managing your stress and you're dealing with overwhelming stress day to day, obviously that should be your focus. And you can approach that with a simple exercise, deep breathing, sitting quietly for 10 minutes twice a day. All of these things will bring you much further toward optimal health.
Very nice. James, when you were preparing for this show, is there anything we didn't discuss that you really wanted to bring out to our audience?
I think you've covered the bases, Glenn. I think that you've asked a lot of interesting philosophical and theoretical questions, so I've enjoyed it.
We have too. I think it's been enlightening for all of us. Can we choose happiness, by the way?
You're asking a lot of daunting questions, my friend. You need to meet down in Santa Barbara over a beer for 5 hours. The Buddhist would say that if you practice in a skillful way, then you can develop the capacity to choose happiness. Because the obscurations, the kinds of psychological factors that get in the way of the possibility of happiness can be understood, acknowledged, and worked through. So you can get to the point after some study of Dharma and meditation work of, in effect, choosing to be happy. However, I believe it's more complex than that, particularly with respect to what we're talking about. If you have a severe mental illness that may be in part mediated genetically or because of your severe psychosocial circumstances, it's very difficult to choose happiness and, in effect, function in a happy way as someone who's content. Your brain may not let you do that. If you're suffering from auditory hallucinations, if you're profoundly depressed because of some genetic predisposition you may have, if you live in a war-torn area, it's difficult to choose happiness. It's not so easy as adopting a frame of mind and following a mindfulness discipline and then choosing happiness. We are blessed in this country to, at least many people are, to be able to have the possibility of choosing a mindset that makes it more likely that we may feel content with our life, with our livelihood. However, many people in this country suffer. There's a lot of suffering here, as we all know. Some people, many people, do not have the means to eat enough, to live in a safe place. And I think it would be superficial of me to make a broad, sweeping comment that people can choose to be happy and therefore achieve happiness if they tried more or more skillfully. I don't think it's quite that simple. It's very complex.
As is everything we do.
This is everything we do.
I'm grateful to our very special guest, Dr. James Lake, for giving us his wisdom and experience and expertise. I would also like to thank my healers and my teachers for allowing me to be on my journey. Thank you, Christina, for being part of this today, and Segovia and Yoga Hub. And we appreciate all of our global audience and participating in Magical Medical Tour. So until our next meeting, I would like to thank Dr. James Lake for everything. And until next week, I wish you all optimal health.
It's been a pleasure. Thank you.
And yes, thank you so much, Dr. Lake. This has been a wonderful, wonderful show. I must say, especially the way you've integrated the healing arts, which I know a lot of my mentors and teachers will be very excited to listen to this show, because we do believe in the non-local energy healing. For many years, we've practiced that. So this is a very exciting show. Thank you so much for sharing that.
Thank you, Christine. I appreciate the opportunity.
And of course, Dr. Glenn Wolman, you're the man. And of course, we would like to thank each and every one of you for joining us in this new platform of education and information. We're grateful for your continuous support, and we look forward to hearing your feedback on how we can serve you better. If you would like to connect with Dr. James Lake, you can do so through his website, theintegrativementalhealthsolution.com. theintegrativementalhealthsolution.com. And he has also given us, of course, the listings to ebooks and other organizations that we will make sure that is on the website as well. And we'll make it much easier for you to reach and contact these organizations. And of course, if you would like to connect with Dr. Glenn Wolman, you can do so through his website, glennwolman.com, where we do always encourage you to learn about his metaphor square breath. And of course, again, we are always grateful for your feedback, comments, suggestions. Please give us a call anytime at 818-LETS-TALK, 818-LETS-TALK. Thank you for joining us today, and until next time, namaste.